Cancers don't just grow on their own, they need hormones to fuel their growth, much like a car needs fuel to run. If you cut off that fuel, the cancer's growth can slow down or even stop. That's the core idea behind hormonal therapy. In this video, we'll break down how hormonal therapy works, why it's used, and what makes it a unique approach in cancer treatment. Whether you're a patient, caregiver, or just curious, understanding this therapy can help demystify one of the most important tools in cancer care. Hormonal therapy, also known as endocrine therapy, is a treatment used against cancers whose cells rely on hormones to grow. The most common cancers treated this way include breast, prostate, endometrial, and adrenal cancers. The therapy works by either stopping the body from making the hormone, blocking the hormone from attaching to cancer cells, or altering the hormone so it can't send its growth signal. Most often, hormonal therapy is used to control disease and relieve symptoms, rather than to cure the cancer outright. Hormonal therapy works in three main ways. First, by stopping the body from producing the hormone in the first place. Second, by blocking the hormone from attaching to receptors on the cancer cell. And third, by altering the hormone itself so it can no longer send its growth signal. Each of these strategies targets a different step in the hormone-cancer connection, aiming to cut off the cancer's fuel supply and slow or stop its growth. Start with breast cancer. Many breast cancer cells have receptors for estrogen or progesterone. Doctors call these ER-positive or PR-positive cancers. Think of the receptor as a lock and the hormone as a key. When estrogen fits into that lock, it tells the cancer cell to grow and divide. Hormonal therapy is designed to jam that lock, remove the key, or even destroy the lock altogether, stopping the cancer from getting the growth signals it needs. First class of hormonal therapy drugs for breast cancer is called SERMs, selective estrogen receptor modulators. Tamoxifen is the classic example. It works by physically occupying the estrogen receptor on the breast cancer cell, blocking estrogen from binding there. What's unique about SERMs is that they don't act the same way everywhere in the body. For example, tamoxifen blocks estrogen in breast tissue, but can act more like estrogen in the uterus. Because it doesn't rely on stopping estrogen production, tamoxifen works for both premenopausal and postmenopausal women. Next are aromatase inhibitors, or AIs, drugs like Anastrozole, Letrozole, and Exemestane. After menopause, the ovaries mostly stop working, so the body's estrogen comes from converting androgens into estrogen through an enzyme called aromatase. AIs block that enzyme, cutting off the estrogen supply at its source. Because premenopausal women still have ovaries making estrogen, AIs are mainly used in postmenopausal women, where they can reduce cancer recurrence rates even more than tamoxifen alone. What about premenopausal women who could still benefit from an aromatase inhibitor? That's where ovarian function suppression comes in. LHRH agonists like Goserelin or Leuprolide shut down ovarian estrogen production, essentially inducing a temporary menopause through medication rather than surgery. This approach is never used alone. It's paired with tamoxifen or an aromatase inhibitor. For high-risk premenopausal patients, this combination can meaningfully improve disease-free survival. Fourth class is SERDs, selective estrogen receptor degraders such as Fulvestrant. Instead of just blocking the receptor, SERDs bind to it and mark it for destruction, physically reducing the number of estrogen receptors on the cancer cell. They're generally reserved for postmenopausal women with advanced or metastatic hormone receptor-positive breast cancer, often after other hormonal treatments have stopped working. Across these therapies, patients commonly experience hot flashes, night sweats, vaginal dryness, changes in the menstrual cycle, fatigue, and joint or muscle pain. Each class also has its own specific risks. SERMs like tamoxifen carry a higher risk of blood clots and uterine changes, including endometrial cancer, while aromatase inhibitors increase the risk of bone thinning or osteoporosis, since they eliminate the small protective amount of estrogen postmenopausal women still have. Now let's shift to prostate cancer, where the driving hormones are androgens, mainly testosterone and its more potent form dihydrotestosterone or DHT. The treatment strategy here is called Androgen Deprivation Therapy or ADT. The goal is the same as in breast cancer: cut off the hormone fuel supply. There are several distinct ways doctors achieve this, each targeting a different part of the hormone pathway. LHRH agonists, Leuprolide, Goserelin, and triptorelin work on the pituitary gland. Interestingly, they start by stimulating it, which causes a brief surge or flare in testosterone before continuous use shuts production down. That flare can temporarily worsen symptoms like bone pain, so doctors often add a short course of an anti-androgen alongside the first injections to blunt that spike. LHRH antagonists like degarelix and relugolix take a more direct route. Rather than triggering a burst of activity first, they block the LHRH receptor from the very start. The result is a fast drop in testosterone with no flare reaction, which can be important for patients whose disease could be worsened by even a brief testosterone spike. Some prostate cancer cells can actually make their own androgens outside the testicles, including in the adrenal glands. Abiraterone targets this by blocking an enzyme called CYP17 that's essential for androgen production throughout the body. This cuts off that backup fuel supply, making it harder for the cancer to keep growing. Final strategy is blocking the androgen receptor directly with anti-androgens. First-generation drugs like flutamide and bicalutamide prevent testosterone and DHT from binding to their receptor on the cancer cell. Newer, second-generation agents, enzalutamide, apalutamide, and darolutamide, are more potent and can still work even after the older drugs have stopped being effective. Hormonal therapy for prostate cancer is used in several settings: to shrink and slow advanced or metastatic disease, alongside radiation for high-risk localized cancer, and for cancer that returns after initial treatment. Even when cancer keeps growing despite low testosterone, a state called castration-resistant prostate cancer, newer agents like Abiraterone and second-generation anti-androgens can still offer benefit. Because ADT lowers testosterone throughout the body, side effects extend well beyond the prostate. Patients may experience reduced libido, erectile dysfunction, hot flashes, bone thinning with a higher fracture risk, loss of muscle mass, fatigue, weight gain, mood changes, breast tenderness or enlargement, and an increased risk of cardiovascular problems like diabetes and heart disease. These are important issues for patients to discuss with their healthcare team before starting therapy. Hormonal therapy is also used in endometrial cancer, especially for women who cannot undergo surgery or radiation. Progestins, a type of synthetic hormone, are commonly used to slow the growth of endometrial cancer cells. This approach can help control symptoms and sometimes shrink tumors, offering another option for patients with limited treatment choices. In adrenal cancers, hormonal therapy may be used to block the production or effects of hormones like cortisol or androgens. Drugs such as midostane can help reduce hormone levels and control symptoms, especially in advanced cases. This approach is often combined with other treatments to improve outcomes for patients with adrenal cancer. Hormone receptors are proteins found on the surface or inside certain cells. They act like locks, and hormones are the keys. When the right hormone binds to its receptor, it sends a signal that can trigger cell growth and division. In hormone-sensitive cancers, blocking or destroying these receptors is a key strategy to stop cancer growth. Hormonal therapy is often used for disease control and symptom relief, rather than as a cure. That's because while it can slow or stop cancer growth, it doesn't always eliminate every cancer cell. Over time, some cancer cells may adapt and find ways to grow without the hormone, making other treatments necessary. Hormonal therapy is often combined with other treatments like surgery, radiation, or chemotherapy. This combination can improve outcomes by attacking the cancer from multiple angles. For example, hormonal therapy might be used before surgery to shrink a tumor or after radiation to reduce the risk of recurrence. Not every patient receives the same hormonal therapy. Doctors consider factors like age, menopausal status, cancer stage, and previous treatments to choose the best approach. Personalized therapy helps maximize benefits and minimize side effects, making treatment more effective and tolerable for each individual. During hormonal therapy, doctors regularly monitor patients for effectiveness and side effects. Blood tests, imaging, and symptom tracking help guide adjustments to the treatment plan. If the cancer stops responding, doctors may switch to a different drug or combine therapies for better control. Managing side effects is an important part of hormonal therapy. Doctors may recommend lifestyle changes, medications, or supportive care to help patients cope with symptoms like hot flashes, fatigue, or bone loss. Open communication with the healthcare team ensures side effects are addressed promptly. Hormonal therapy can provide long-term control of hormone-sensitive cancers, especially when started early and used consistently. Some patients remain on therapy for years, with regular follow-up to monitor for recurrence or late side effects. The goal is to maintain quality of life while keeping the cancer under control. Over time, some cancers may become resistant to hormonal therapy. This means the cancer finds ways to grow even without the hormone it once depended on. When this happens, doctors may switch to other treatments or use newer hormonal agents that work differently to regain control. Research is ongoing to develop new hormonal therapies and combinations that are more effective and have fewer side effects. Scientists are also studying how to better predict which patients will benefit most from each type of therapy. The future of hormonal therapy is focused on precision medicine and improving patient outcomes. Education and support are vital for patients undergoing hormonal therapy. Understanding how the therapy works, what to expect, and how to manage side effects empowers patients to take an active role in their care. Support groups and counseling can also help patients cope with the emotional and physical challenges of treatment. Whether it's estrogen driving a breast cancer cell or testosterone driving a prostate cancer cell, hormonal therapy works on one core idea: cut off the hormone that the cancer depends on and you take away its ability to grow. From SERMs and aromatase inhibitors to LHRH agonists and anti-androgens, each drug class attacks that fuel line at a different point: production, transport, or the receptor itself. Hormonal therapy is a powerful tool in the fight against hormone-sensitive cancers. By understanding how it works, the different drug classes, and the importance of monitoring and support, patients and caregivers can make informed decisions about treatment. As research continues, hormonal therapy will likely become even more personalized and effective, offering hope to many facing cancer.